Welcome to our third and final webinar on navicular syndrome in horses. And in our last section, we discussed how we go about diagnosing the condition and the imaging modalities we use, including, radiography, MRI, and scintigraphy or bone scanning. In this session, we're going to talk about approaches to treatment. And strategies for treatment have changed greatly for horses presenting with navicular syndrome type lameness. A large percentage of horses that were previously presumed to have navicular disease, in fact, after MRI, were shown to have other conditions. Each of these are treated in a different manner. The old premise of no foot, no horse still holds true. And I think foot conformation, proper trimming, proper conformation of the foot is so important, not just for foot lameness, but in fact for other lamenesses further up the leg and even relating to back injuries. And so that still holds true today. Corrective trimming is really important. Here we have an interesting case. It's very muddy foot, but it really demonstrates what I would call a broken back foot pastern axis. That top red arrow should be a straight line going from the line of the pastern bone in along with the coffin bone. And if that line is what we call broken back due to too long of a toe or too low of a heel, this means we're putting too much pressure on the back of the foot and on the structures of the back of the foot, including the navicular bone and the deep digital flexor tendon and the other structures there. So one of the first things that must be done is to shorten the toe and to correct this broken hoof pastern axis. Rolling the toe can be helpful as well to help the break over, and perhaps a slight raise on the heel, which will take some of the pressure off the deep digital flexor tendon. We use egg bar shoes in some instances, and they will give support to the back of the foot, especially if the foot has been collapsed. And you can see with this egg bar shoe, it is actually wider than the foot itself. And the reason for this is we want to encourage the foot and the heel to grow out and to spread. And the old adage of making the shoe fit the horse is actually, in my view, not correct. You'd actually make the foot fit the shoe. Because if you've got a foot that has collapsed the heel or even a boxy, narrow heel, we want to encourage those heels to spread. So therefore, by having a slightly wider shoe, it encourages the foot to follow the shoe. Some farriers or some people make the mistake of, if the heel is collapsing, they bring the shoe in following the heel, which only makes the heel collapse more. So in this is a very obvious example of a very wide cover at the heel, and the shoe is coming very back past the bulbs of the heel almost. Of course, with these type of horses and with this type of shoe, egg bar shoe on, if they go out in the field, do uncontrolled exercise, they'll be far more prone to pulling the shoe off. So during the rehabilitatory period, the horses should be either in a very small confined paddock where they can't gallop around, or kept in the stable. Equally, when you're riding them, if you kind of are riding on a sloppy, loose rein and there's a risk of them forging, only a slight risk. But once ridden in a normal, competent manner, getting a good hold of the head and good use of the leg and keeping the hind legs engaged, you'll have no problem with these shoes. In fact, I've got horses that even compete with these shoes. Here we've just got an example where we put a slight raise in the heel to take the pressure off the deep digital flexor tendon. Now, very often horses with heel pain or navicular pain, the raised heel would immediately give them relief. I would stress this is not a long-term answer, because pads or raised heels do encourage poor heel shape. So they are a temporary measure to help the acute pain and to help to rehabilitate the horse. Here we've got an example of a contracted heel and a normal hoof. And I would just like to re-emphasize that the foot should fit the shoe rather than the shoe fit the foot. Further example of extremely poor foot conformation, and these are obviously very extreme cases, but just to make the point that on the left we have where the toe is far too long. We've got a broken back hoof pastern axis, and we can see on the radiograph on the right where the pedal bone is actually sitting up, and in fact the pedal bone should be sitting in the opposite direction. That almost should be slightly raised up. In this case there's a lot of pressure on the navicular bone and a lot of pressure on the deep digital flexor tendon. And even though these are extreme examples, every day I see horses where the toes are too long. I just would like to show you some frog support shoes that we have been using recently, and these have been developed by a farrier in Germany called Michael Poole, who has really developed a very simple idea. And going back to our previous discussions where we said frog pressure is so important in stimulating blood supply through the foot, through the navicular bone, through all these structures, and most of the shoeing techniques that we use nowadays do not give good frog support. Even a reg bar shoe, which is good, still doesn't give frog support. And he has developed these shoes where are these pads that fit between the shoe and the hoof. They have a slight raise at the back of the heel to relieve pressure off deep digital flexor tendon, but they also have got a frog shaped depression where we can put hoof packing material, which gives, so when the foot hits the ground with the shoe on, it engages the frog and gives support to the frog, which in turn gives support to the navicular bone, the deep digital flexor tendon, the structures back there, but also encourages good blood supply. And we have found these pads to be extremely good in very many cases. This is an interesting new device that we have just brought in at Troytown. It was developed by a farrier in the United States who's involved in barrel racing horses. We don't have many barrel racing horses here in Ireland, but he came up with a very interesting concept because, you know, it was his view that horses given a raise in their shoe at various points often gives them relief and often encourages healing. But he was never quite sure where to put the raise. So he's developed this prosthetic device that has got a wedge on it that has got 8 different positions. And the idea of it is that this wedge is put onto the lame foot, and we make a recording of how easy or how difficult it is to pick up the sound foot with the horse bearing full weight on the lame leg. And with the wedge in different positions, there are different levels of comfort. So for example, if the horse has a collateral ligament injury and we put the wedge over the collateral ligament, he finds it extremely painful to pick up the opposite leg. But if we put the wedge on the far side, he finds it extremely comfortable. So on the right we have a chart. We make a recording of the areas where it's comfortable or not comfortable by picking up the opposite leg. And that can then give us a map to develop a therapeutic shoe to make this horse comfortable just during the rehabilitatory period. I would stress it is not a situation that this shoe will be used for the rest of the horse's life. Other parts of treatment are regular exercise on a good surface. We discussed earlier that often irregular exercise or a change in exercise routine can give rise to the symptoms of navicular syndrome developing, or maybe working on poor ground, or maybe the horse doing too much jumping. So therefore, regular exercise on good ground, avoiding jumping, stimulates blood circulation through the foot and helps to promote healing. Rest or complete box rest is not necessarily helpful. It's rather controlled exercise is more useful. There are various medications that we use in foot lameness, and the obvious one we've all heard about is equipalizone or bute. And this has a place but must be used judiciously. Obviously, bute is a painkiller, but as well as being a painkiller, it is a anti-inflammatory drug. So it will take inflammation down away from an area. We do not want to use bute just as a painkiller and just to eliminate it and carry on regardless. However, if it allows us to rehabilitate the horse, to get the horse doing a small amount of work with a low level of bute, it has its place. This next brings us to an interesting product, isoxaprine. Unfortunately, isoxaprine is no longer legally available in the Republic of Ireland. It is available in the UK, the north of Ireland, and in Europe. It is slightly controversial, but in my experience has been very good in some cases of navicular syndrome. There are many papers published, and there are veterinary surgeons who say that isoxaprine is not absorbed from horses' gut. But recent studies have shown after administration of isoxaprine that there's a significant increase in the limb temperatures for 8 hours post-administration. What isoxaprine does is it dilates blood vessels in the periphery of the body, most specifically in the bottom in the foot area. And by increasing, the theory goes, by increasing the blood supply, this may increase some of the healing benefits. I think some of the disappointment with isoxaprine has been the preparations that have been used. Personally, I have had more success with the Circulon paste rather than the Navilox powder. It should also be given on an empty stomach. And I think, and also we must follow the manufacturer's recommendations as regarding exercise and increasing or decreasing the dose according to response to treatment. It's also important when using Circulon to be aware of doping regulations, and also must be aware of contamination of other horses' feed, as if some of the paste gets on one bucket for the horse you're treating and is then transferred into the horse next door, and that horse was to compete, he could come up positive. So great care needs to be used when you're using Circulon paste. This leads on to my just personal experience of isoxaprine, and I think there's nothing like having personal experience and having success. I mean, 20 years ago, when I was eventing in England, the horse that I rode had navicular syndrome, and I tried everything to get him sound. And by intensively using Circulon paste, I brought this horse sound and brought him right up to advanced level where he competed in international 3-day events. So, I think personal experience has taught me that Circulon paste, certainly for those people who can avail of it, is definitely worth considering. Intra-articular or intrabursal injections of cortisone have been used and been used with some success. It may help in cases where there are only moderate navicular bone changes. There are risks associated with injecting the navicular bursa. On the right, we can see where the needle is going right through the deep digital flexor tendon into the navicular bursa at the back of the navicular bone. And in most cases, this is uneventful. But sometimes, if a horse moves suddenly, there can be tears occurring in the deep digital flexor tendon, so it needs to be done with great care. This is the type of cortisone injection that we generally use, triamcinolone, and again, it is useful, but withdrawal times must be adhered to for competition. Another drug that has recently come into use is a drug called Tildren, and Tildrenate is a bisphosphonate drug which originates from the use of this in old ladies with osteoporosis of their bones, and bisphosphonate actually encourages bone activity and laying down of stronger bone where there is bone edema or bone inflammation. Recent studies in France have shown very good results for navicular disease, but some other studies have been varied in their response. There are a number of ways the drug can be used. It can be given by intravenous drips, but what we have been doing at Troytown now is by doing regional perfusion of this drug, and that is where we put a tourniquet onto the distal limb, and then we inject the drug below the tourniquet, so which it just floods the whole area with this drug. And the aim is to build up the strength of the navicular bone. There may also be some pain relieving effect with this drug as well. Shockwave therapy. We don't specifically use it for pain with the navicular bone anymore, but there are very many other conditions in the foot, such as collateral ligament injury or suspensory ligament injury, where shockwave therapy is very beneficial. And this is where accurate diagnosis with the MRI identifies the problem, and we can then direct shockwave specifically to encourage healing. Another recent development is platelet-rich plasma or stem cell therapy. This is used in a number of situations, but most specifically where we have a tear in the deep digital flexor tendon. Tears in tendons are very slow to heal, and we need something to try and stimulate the fibroblasts to produce healing within the tendon. Platelet-rich plasma is a very new technique, but is very effective. It is where we collect blood from the horse and we spin down that blood and we collect and concentrate the platelets. Within those platelets are a myriad of growth factors. And by concentrating those growth factors together and then injecting them in the concentrated form into the injured area of tendon, it then stimulates the tendon to heal. We also use platelet-rich plasma into joints, into the coffin joint and into the navicular bursa, and there they also have a very good healing effect. This is very new therapy, but we are very, very happy with it since we have introduced it. Stable rest is generally not recommended for navicular disease, but where we have identified a tear in the deep digital flexor tendon, absolutely the horse has to be rested while the tendon is knitting and healing. And this again is where errors are made, where a false diagnosis of navicular disease is made, and we are continuing on with controlled exercise, which is only exacerbating the tear in the deep digital flexor tendon. Whereas having identified the deep digital flexor tear, which really can only be done by MRI scan, and if we know of its presence, we can then rest the horse for varying lengths of time. Some deep digital flexor tears have a poor prognosis, but some of the more minor ones have good outcomes provided the horse is rested sufficiently and has other adjunctive therapies such as platelet-rich plasma or stem cell therapy. Other options that are open to us are, in rare situations, are an arthroscopic investigation of the navicular bursa, if in case there are any adhesions in this area, and these adhesions can be broken down. Sectioning of the collateral sesamoidean ligaments in certain situations can give temporary relief. There was a study done by Ian Wright, which had shown very good response for up to 18 months post-surgery with sectioning of the collateral sesamoidean ligaments. It was felt initially that this was due to an alteration in the position of the navicular bone at the back of the leg, but we now feel it is due to the fact that there are two small nerves that run through the collateral sesamoidean ligament, and it probably acts like a partial denerving. I suppose lastly, as a last-ditch resort for managing horses with chronic navicular, is to do a palmar digital neurectomy. And this is a reasonable option for non-competition horses. It is not permitted under the FAI rules to compete with horses that have been denerved. But for leisure horses, riding club horses, hunters, it does increase the longevity of the horse's life, often for a year, 2 years, maybe even 3 years. And it, once done cautiously, and that the horse's foot is inspected every day to make sure that no nails have gone up into the foot, there are no detrimental effects. And horses seem to have, they do not lose proprioception of where their foot is. They do not seem to increase the incidence of stumbling. So this is a last-ditch treatment just to help keep your horse on the road. In addition, there are a myriad of other medications in the market, such as Equine, cartiphen, glucosamine, chondroitin, calcium and supplements. And I have no objection to these being used, but I don't think they specifically make that much difference for navicular disease. If we have got a horse that has got osteoarthritis of the coffin joint, or has got maybe early ring bone, or other conditions, then your cartiphen, glucosamine and chondroitin may have a place to play. And that's why I think it's very important to discuss with your vet the full details of the treatment regime, so you're not wasting money on supplements that are maybe not doing any good. It's not done so much in this country, but on the continent there are chemical neurectomies being done, and that is where a plant alkaloid is injected over the nerve, which will temporarily freeze that nerve for up to about 3 months. In conclusion, every horse is an individual, and all respond differently to different treatment regimes. And I'd even go so far to say is that we might have the exact same condition in 2 horses, and both will respond to a different therapeutic program. But I must say, it is most important to make a correct diagnosis in the first place. That is the most important thing, and we would contend that MRI is essential for this. And then you make a treatment plan on this, going step by step. So perhaps the final solution is to remove the front limbs from the horse, and then we would have no more navicular disease. I'd like to thank you for listening, and hopefully most of you have followed all 3 webinars, and I hope you have found it of use to learn how we go about diagnosing the condition, what imaging modalities we recommend. And I suppose the point we would say is that MRI is very useful, and in the longer term does give value for money in doing it. And having major proper diagnosis, we have then gone over the treatment options open to us, and I hope we have just scratch the surface really of how we go about treating it, but it just gives you an idea of what we can do and the approaches that we are taking, and that the importance of the good diagnosis, a logical approach to your treatment programs, and perseverance with your treatment. And we were emphasizing how different horses respond to different types of treatment. But once you're confident with your diagnosis, you can start off with one line of treatment, and if it's not getting the results that you had hoped for, we can then tweak that treatment until we can try and get a result. And I think more and more often we are getting these horses back on the road and back competing. So again, thank you very much for listening.